I'm Dr. Abhilasha Yadav from Datta Meghe Institute of Medical Sciences, Savangi, India. I'll be talking about cleft nose, improving aesthetic outcomes. As we all know, rhinoplasty occupies a unique position in facial surgery due to the central position of nose in the face and vital functions of the nose. But here today, I'll be talking about the cleft nose. Cleft nose in the sense in the patients in which we do repair cleft lip and cleft palate, which further require the repair of nose. In 30% of patients, the cleft is accompanied by additional physical or cognitive abnormalities. Those who routinely perform cleft rhinoplasty, in addition to cosmetic or functional rhinoplasty in the non-cleft patient, readily acknowledge that cleft septorhinoplasty is the single most challenging rhinoplasty to perform. Basically, there are 5 types of cleft patients presenting for rhinoplasty. They can be divided into group 1, in which the patients they have undergone surgery in childhood, that is during the lip repair. It can further be classified as group 1A. Then group 1B, in which the patients may or may not had the primary surgery in the form of rhinoplasty. In some, rhinoplasty was done around 6 to 9 years of age. That is called as a preschool rhinoplasty. This is usually done in patients who demand, the parents who demand that the nose should be corrected before the child goes to the school, and with suboptimal cleft surgeries. Then we have the group 2. These are the patients who present first time for the cleft surgery. By that age, they have not done their cleft lip or the cleft palate surgery. Now, what are the patient presentation? In group 1A, the patients who had primary rhinoplasty and gingivoperioplasty, almost 40% of patients may not require a secondary rhinoplasty. If during the time of lip repair, a primary rhinoplasty along with septum placement in the midline has been done, then the secondary rhinoplasty can be avoided in the cleft patients. There is alveolar alignment due to the gingivoperioplasty, which further prevents secondary rhinoplasty. Alveolar bone grafting may be obviated, and so as a secondary rhinoplasty. In group 1B patients with or without rhinoplasty, we can see the nasal deformities. We can have secondary lip deformities in the form of lip pulling, notch, whistle deformity. We can have retrognathic maxilla and nasal deformity in the form of depressed alar base, depressed columella, widened nostril sill. In group 2 patients who present for the first time for surgery, almost 20% of unilateral cleft lip, cleft palate patients present in teens or later years in the developing world, and more than 80% of world population lives in the developing world. This guy, he reported to our center when he was 50 years of age. Till that time he was living with this defect. He just came because his grandchildren were afraid of him, scared of him. So he wanted a repair of his cleft lip and cleft palate. As he was a daily wage worker, whatever we could do in a single sitting, we did for him. I'll show you the results later. Now, what are the patient presentations in group 2? They have a hypoplastic maxilla, distorted direction of growth from aberrant muscle pull, which leads to discrepancy in the lesser and the greater segments. The patient himself or herself is concerned for aesthetics. As nasal correction is the end result of an overall treatment program for cleft lip, it is not sufficient to just offer a lip repair. Therefore, before rhinoplasty is done, a sequence of surgeries has to be done for the cleft patient, which is the lip repair, the palate repair, followed by alveolar bone grafting at a specific age, if required orthognathic surgery for the correction of hypoplastic maxilla, and rhinoplasty is the last thing to be done in cleft cases. Explore if all facets of deformity can be addressed in a single stage for maximal benefit. Broadly, the cleft rhinoplasty can be divided into primary, preschool, and the secondary rhinoplasty. Now, the primary rhinoplasty is performed with the following goals in mind. It should have balanced alar basis, columnar base mobilization to the midline, caudal septal release and repositioning, alar base release and repositioning, lateral piriform release and repositioning, anteromedial advancement of cleft side dome and lateral crus, lateralization of cleft side lateral vestibular lining, support, no external skin incisions should be there, and no excision of skin envelope, because already in cleft cases the tissue is already deficient. Now coming on to nasoalveolar molding, I guess this terminology would be new for you. We being maxillofacial surgeons, we being dentists, our orthodontic friends, they perform nasoalveolar molding for our cleft cases. What is nasoalveolar molding? It is a non-surgical method of reshaping the gum, lip and nostrils. NAM is used mainly for children with large cleft defects, in which the lesser and the greater segments are wide apart. It is employed in early management of both unilateral as well as bilateral cleft lip, cleft palate patients, and it is started from 2 weeks of birth. Nowadays, even if the kid comes to our institute from say around 2 to 3 days of birth, we do start the treatment. This is an example showing a wide unilateral cleft lip case. The lesser and the greater segments are wide apart. You can see a wide gap, flattened nose. Now what is done is, a custom made tray is prepared for the kid after taking an impression to bring the alveolar segments close together. With the help of tapes and elastics, the alveolar segments are molded. Once the gap is reduced, once the segments come around 6 to 7 millimeters close together, then a nasal stent is added to the plate. This raises a nasal dome. These are the pre-therapy treatment, pre-therapy pictures. You can see the cleft has reduced in size and the nostril, it has been raised. This also aids the surgeon while performing lip surgery. This is again an example of how the plate is placed in the patient's mouth and the nasal stent is added. This is the nasal stent in situ. This is a reduced space. Here you can see the lip surgery along with primary rhinoplasty being performed, and this is the post-op result. This is a case of bilateral cleft lip, cleft palate, wherein you can see the premaxilla is protruding outside the lesser segments. Similarly, an impression is taken and a custom-made tray is prepared for the patient. Lip taping is done. With the help of elastics, the premaxilla and the lesser segments are brought together. After the premaxilla has come down, you can see a nasal stent is added onto the plate. This is the post-op result, frontal view and lateral view, wherein you can see the nose has come down very nicely. In bilateral patients, we do have a problem with the columella, which further they require secondary rhinoplasty at a later age. This is again a case of Binder syndrome, wherein the patient had a nasomaxillary hypoplasia. The premaxilla was absent. This is only the prolabium part which is present. So similarly, appliance was prepared for him and the lip surgery was done, though he may further require some revision surgeries later. Apart from the plate, in some cases where the lesser and the greater segments are not much wide, some other form of appliances can be used to raise the nasal or to mold the nasal cartilages. This is a pre-surgical nasal corrector wherein no plate was given to the patient, only the wire elements were given to raise the nostril. This is another case wherein the lip surgery was performed using the same appliance. This is again a case of midline cleft palate. The central portion of the premaxilla was missing, so the lip surgery was done. Columella, though it is deficient, may require secondary corrections later. We fabricated a conformer for the patient to maintain the nostril width because one of the nostril was blocked. We do follow our cases treated with NAM and see the results, long-term results. These are few of the results wherein you can see the patient was treated with nasoalveolar molding, surgery was performed. This is 6 months post-op, 2 years post-op, 4 years post-op. The nasal results are consistent. Again few cases. wherein we have 5 years of follow-up and still the nasal results are consistent. Some cases may require secondary rhinoplasty at a later age. In some patients who come under the group 1B category, they report late to the institute, wherein whatever we have to do, we do in a same sitting. So for this case, only a cleft lip and a bit of nasal deformity was present, which was corrected in a single sitting while doing a lip repair along with rhinoplasty. This guy I was talking about, for him we carried out a cleft palate repair, lip surgery as well as a rhinoplasty. This is how when he came, and this is how he left our institute. This is a pre and the post-op result, though he didn't turn up for follow-up. This is the worm's eye view, the pre-op and the post-op. Now coming on to secondary rhinoplasty. This plays a very important role. As I've said earlier, secondary rhinoplasty should be carried out after all the other procedures have been done. For example, the heart tissue in cases of alveolar bone grafting or orthognathic surgery, then you should go for secondary rhinoplasty in cleft cases. This was a case wherein only a rhinoplasty was performed. After alveolar bone grafting, her premaxilla was not as such retognathic, so orthognathic surgery was not required for her. Here in secondary rhinoplasty, here in cases, you can see that the level of the nasal base is so much difference in the base. The dome is depressed, columella is less. We did a rhinoplasty for her. These are the immediate post-op results, the worm's view and the frontal view. Same patient. In some cases, there is very much deviation of the septum. The patient also complains of breathing difficulties. So in those cases, we do need to go along with rhinoplasty, we do a septoplasty also. So combining the septorhinoplasty, we do lip revision surgeries in the same sitting as well. Herein you can see the difference in the level of the cartilages. After correcting the cartilages, the septum is centralized. Lip revision is done in the same sitting along with rhinoplasty, and this is a pre-op and post-op result. This is again a case of septorhinoplasty. Inverted U or Tajima incision is taken. As I've already told, excess skin is not to be discarded. So whatever you can use, it can be used. Tajima incision is taken, and we in cleft cases, we prefer a V to Y incision so as to lengthen the columella. If septum cartilage or a graft is required, we take a graft from the septum or say a post-auricular cartilage, and we use as a columella strut to lengthen the length of columella. In the same sitting, lip revision, minor corrections, whatever needed are done. This is the pre-op and the post-op result. Worm's view. One more case, the pre-op and the post-op. Worm's view, frontal view. This is again a case. She was a student, college-going student, but she was very depressed. She came to our institute. We did alveolar bone grafting for her. She was not happy with her lip and her nose, so we did a rhinoplasty as well as lip revision in the same sitting. And this is her post-op. This patient had a very wide gap in between the segments. Alveolar bone grafting was not possible as her defect was very big. So we did a distraction for her. We distracted the lesser segment and what in between. The gap which was the new bone which was formed there, we placed implants in her and a rhinoplasty was done, and this is her post-op. So what to conclude, we would say that ours is a small step towards a long march. Only such steps everywhere in the world ultimately will benefit the mankind and leave its footprints on the sands of time. I would like to acknowledge Smile Train. Our sincere thanks to Smile Train, because of them we could do such things. Thank you.
Thank you, Dr. Yadav, for the wonderful presentation. We entertain comments, questions. Sir.
I think it's a wonderful presentation. The results look very good. Did you involve plastic and ENT people in your work?
Yes, sir. We do have a cleft team in our institute.
Yeah.
It's a comprehensive work.
Right.
We don't work.
Otherwise, this kind of results are very difficult to bring out because you need a multidisciplinary approach.
Yes, sir. It's a multidisciplinary.
Everybody has to do their own part.
We have a cleft team wherein we have pediatricians also included in that, ENT surgeons, plastic surgeons, orthodontics, dentists, and maxillofacial surgeons.
What he's saying is that you probably should have just mentioned in one of your slides. You would have prevented that question.
And on an average, how many cases do you do yearly?
Sir, not only rhinoplasty, but we do primary surgeries also. So on an average, around 360 cases in a year. We have a smile train center